Started? Okay, done. Welcome back, guys. Now we are doing endocrine pathology, right? In yesterday's class, we done the thyroid pathologies. Okay, in yesterday's class, we done with the thyroid pathologies, and I said that today we'll be continuing with the parathyroid disorders. Okay, of course, it was scheduled to do in last class the parathyroid disorders, but unfortunately, it's yesterday it took almost 2 hours class. So let's continue with the parathyroid disorders in this today's class. Okay, so without any further late, let's begin the topic, the parathyroid glands. Now, look here, I'm going from the basics. Let me go do it from the basics. Okay, first let me tell you what is the normal functions of the parathyroid and parathyroid disorders. So, how many parathyroid glands do we have? See, this is the thyroid gland. Okay. So, how many parathyroid glands do we have? There are 4 parathyroid glands, out of which 2 are superior parathyroid glands. Oh my God. Yeah. 2 are superior parathyroid glands and 2 are inferior parathyroid glands. Now, MCQ which can be asked in the exam is, so the superior parathyroid glands, dekho. Okay, the superior parathyroid glands, they are derived from where? They are derived from the 4th pharyngeal pouch. Okay, it's derived from the 4th pharyngeal pouch, and the inferior parathyroid gland is derived from the 3rd pharyngeal pouch. Okay, you know the pharyngeal pouches, right? You know these things. Okay, these things called as the pharyngeal arches. These pharyngeal arches, they consist of a pharyngeal pouch as well as a pharyngeal cleft. Okay, you know these things, right? For example, now I'm making a cross section over here. Now, for example, look here, I'm just making a cross section over here, and I'm showing you this is the first pharyngeal arch, second pharyngeal arch, third, fourth, and there is no fifth, sixth. Okay, now look here. See, these depressions which I am showing you on this side, these are called as pharyngeal pouches. They are called as the pouches. On this side, there is pharyngeal cleft. Okay, pharyngeal cleft. Now, what I have discussed with you, 4th pharyngeal pouch, from this area, from this 4th pharyngeal pouch, who is going to be developed? Superior parathyroid gland. And from the 3rd pharyngeal pouch, who is going to be developed? It's the inferior parathyroid gland. Okay, it's the inferior parathyroid gland. Now itself I am telling you, don't forget, from the 3rd pouch, even thymus getting developed. Okay, thymus is getting developed from the 3rd pharyngeal pouch. So tell me, the parathyroid glands are derived from pharyngeal pouches. Which pharyngeal pouches? 3rd and 4th pharyngeal pouches. Okay, I used to remember something like, see, 4 is bigger number, right? The 4 is a bigger number, so superior. Okay, so superior parathyroid glands are derived from the 4th pharyngeal pouch, and inferior means less number, 3rd pharyngeal pouch. So 3 and 4, superior and inferior, simple. Okay, now done. After this, let me discuss about the histology. So what's there inside this parathyroid glands? So what exactly is there inside this parathyroid glands? So the parathyroid glands are made up of chief cells, also called as C cells. Okay, so what these parathyroid glands are going to secrete? They secrete a hormone called as parathyroid hormone. What is the function of the parathyroid hormone? The parathyroid hormones increases the blood levels of calcium, MCQ. Parathyroid hormone increases the blood level of calcium and decreases the blood levels of phosphate. So parathyroid hormone is having 2 functions. Function number 1 is it increases the blood calcium levels. How it increases the blood calcium levels, that I will discuss. It will decrease the phosphate levels. Okay, phosphate levels. So that's why I used to remember like parathyroid hormone as phosphate trashing hormone, phosphate trash, keeping the phosphate in the trash. Okay, decreasing the phosphate levels in the body, excrete the phosphates out of the body. So that's why phosphate trashing hormone, just like a mnemonic kind of thing. Parathyroid hormone, phosphate trashing hormone. What are the 2 functions? One is increasing the blood calcium levels and other is decreasing the blood phosphate levels. Now, next question is how? How? Question how? How is parathyroid hormone? How parathyroid hormone increases the blood calcium levels? Okay, let me write here the functions. Functions of parathyroid hormone. See, the number 1 function is parathyroid hormone. It activates, okay, the parathyroid hormone, it activates an enzyme. Okay, it activates an enzyme called as alpha-1 hydroxylase. Where this alpha-1 hydroxylase is present? It is present in the proximal convoluted tubule. Parathyroid hormone, it activates an enzyme called as alpha-1 hydroxylase. When the alpha-1 hydroxylase is activated, do you know what it will do? It helps in activation. What it will do? It helps in the activation of vitamin D. It helps in the activation of vitamin D. Okay, vitamin D. is going to be activated. What is the active form of vitamin D? The active form of vitamin D is called as calcitriol, okay, or 1,25 dihydroxycholecalciferol. All are same, all are same. Active form of vitamin D, calcitriol, 1,25 dihydroxycholecalciferol, okay, 1,25 dihydroxy, 2 hydroxylations, 1,25 dihydroxycholecalciferol, all are same. Now, what is the function of vitamin D? Sir, function of vitamin D, it will go to the intestines, okay, it will go to the intestines in the GIT. There it increases the calcium absorption. So, what parathyroid hormone is doing? I have said you, parathyroid hormones increases the blood calcium levels, by how? By indirectly activating vitamin D. So, you should know parathyroid hormone activates vitamin D. Vitamin D goes to the GIT. In the GIT, it increases the absorption of calcium. Okay, this is first function. The next function of vitamin D is parathyroid hormone. It acts on the kidneys. It acts on the kidneys, especially the distal convoluted tubule. Increases the calcium reabsorption. Okay, increase the calcium reabsorption. See, you need to understand here it is absorption, sir. Number one function. Okay, number one function is the absorption. The new calcium is being absorbed from the GIT. The other function of the parathyroid hormone is by acting on the distal convoluted tubule, MCQ. Parathyroid hormone acts on the distal convoluted tubule, increases the calcium reabsorption. Okay, reabsorption means the calcium is not getting lost in the urine. So, more and more calcium will try to get reabsorbed. This is the second function. Sir, in severe conditions, in high values, okay, hyperparathyroidism in lots and lots of quantities. So, the parathyroid hormone, now do you know what it will do? It activates osteoclasts. Okay, it will give the signal to the osteoclasts, causing bone resorption. Okay, actually parathyroid hormone won't activate the osteoclast directly. First it will activate the osteoblasts. Later they will produce a chemical called as rank ligand. There is a complex mechanism that I will explain you. But for now, just remember parathyroid hormone in super high quantities. Okay, so it's going to activate the osteoclast. When osteoclasts happen, bone resorption means breakage. Okay, bone breakdown is going to happen. So what happened to the blood calcium levels? Increases. The calcium is now mobilized from the bones into the blood. The calcium is being mobilized from the bones into the blood. So what are the three functions of the parathyroid hormone? See, PTH, parathyroid hormone. Three functions. I used to remember something like this. One is absorption, second one is reabsorption, and third one is the resorption. Simple. First one is absorption, second one is reabsorption, third function is bone resorption. Resorption, not reabsorption. Resorption, bone resorption means bone breakage. Okay, so these are the three functions by which it is increasing the blood calcium levels. See, calcium levels are increasing, here also calcium levels are increasing in the blood. So these are the functions of parathyroid hormones. Now here I want you to know one important point here itself. Look guys, this is your bone. Okay, this is your bone, sir. Okay, nice and beautiful bone. Now inside the bone, so there are two fellows present. Okay, two types of cells present. One is looking like a good guy. Okay, simply just looking like a good guy, but later you will understand he is the real villain. Okay, so there is this one fellow present and there is this other fellow present, okay, who looks like a villain but he is actually innocent. Okay. So in the bone there are two types of cells present which are called as osteoblasts and osteoclasts. Okay, osteoblast and osteoclast. What osteoblast will do? Everyone knows. They help in bone formation. Okay, they help in the bone formation, bone build-up. Okay, bone build-up. Osteoclasts, what they will do? They will cause bone resorption. Now, point is the parathyroid hormone. It will come and activate the parathyroid hormone receptors. The parathyroid hormone receptors are present on the osteoblast. Parathyroid hormone activate the osteoblasts. Now this osteoblast, they will produce certain chemicals. Okay, now they will release some chemicals. These chemicals are called as rank. Okay, rank. Okay, receptor activated nuclear factor kappa. Not needed, just simply remember the osteoblasts are going to produce a chemical called as rank. So now this rank, it will come and act on its rank receptor. This is the rank receptor, sir. What exactly is it? This is rank receptor. So where is rank receptor present? Rank receptor is present on the osteoclasts. So this parathyroid hormone, it will come and activate this rank receptor. Now this osteoclasts are activated. Now the activated osteoclast will do the bone resorption. So it's the osteoclastic activity. Every time I say, it's the osteoclastic activity regulated by the osteoblast. It's the osteoblasts regulate the activity of osteoclasts. Then osteoblasts are activated by which hormone? Parathyroid hormone. Parathyroid hormone in high quantities. Okay. Now after this, you know it, like see the parathyroid glands, parathyroid hormone. So by breaking the bone, by bone resorption, they increases the calcium levels in the blood. Parathyroid hormones reduce the calcium clearance, which means decreases the calcium excretion, means increases the calcium reabsorption in the distal convoluted tubule. I have explained you that. And in the intestines, the parathyroid hormone activates vitamin D. So vitamin D, what it will do? Helps in the absorption of calcium. You know it. So functions completed, sir. All the functions I have explained you. Okay, all the functions I have explained you. Say regarding what happens in the kidneys, I have explained you. And what is happening in the bones, that is the osteoblast activates the osteoclast by rank ligand. Okay, you know it, right? So functions done, sir. After the functions, now let me directly go into the disorders. Okay, let me directly jump into the topic of the disorders, sir. There is a hyperparathyroidism. In the name itself, it's there. Hyperparathyroidism, which means what? More amount of parathyroid hormone. Simple, high levels of parathyroid hormone. So what happens if there is high levels of hyperparathyroid hormone? Simply basic, right? More amount of PTH, more calcium is there in the body. That lots and lots of calcium will cause unnecessary problems. Okay, so what's the most common cause? Why, sir? Why hyperparathyroidism? Why more parathyroid hormone? Most common cause is parathyroid adenoma. Look here, this is the parathyroid gland. Sorry, this is the thyroid gland. Okay, this is the thyroid gland. Now, in the thyroid gland, are you able to appreciate? Sir, there is a tumor. Okay, there is a tumor to this parathyroid gland. Parathyroid gland got a tumor. So, it's called as a parathyroid adenoma. So, parathyroid adenoma is the most common cause of primary hyperparathyroidism. Primary hyperparathyroidism. Right now, I am talking about the primary hyperparathyroidism. Primary means there is some problem at the level of gland. Okay, there is some problems are happening at the level of gland. What is that problem? Parathyroid adenoma. Or there can be parathyroid hyperplasias. Okay, parathyroid gland have undergone hyperplasia. Okay, not a tumor, just the parathyroid glands become bigger. Parathyroid hyperplasia, which are seen in syndromes like multiple endocrine neoplasias, Men's syndrome. There will be parathyroid hyperplasia. So, what are the two causes? What are the two causes where the parathyroid hormone levels are going to be elevated? One is parathyroid adenoma. Second one is parathyroid hyperplasias. Done, sir, done. Now, what is the most common site? Which gland can get this adenoma? It's the right inferior gland. Here also they go. Okay, it's the inferior glands. It's the inferior gland. That too, right inferior gland is the most commonly going to develop these adenomas. Okay, so what are the genetics? What are the genetics involved? So, why this parathyroid adenoma? Why? Maybe because of some gene mutation cyclin D1 overactivity. So, cyclin D1 overactivity is associated with parathyroid adenomas, leading to hyperparathyroidism. True. I have explained you. So, this parathyroid hyperplasia, it is associated with what? So, the parathyroid hyperplasias, they are associated with Men's syndromes. Okay, I will discuss about this also in today's class. Sir, in men 1 syndrome, multiple endocrine neoplasia type 1, in men type 1, see, imagine there is this one fellow. Okay, there is this one fellow, sir, who is having men 1. Okay, men 1. So, this patient is going to have 3P tumors. What are these 3P tumors? Pituitary adenomas, means 1P for pituitary adenomas, pituitary gland tumors. Second P is parathyroid adenomas, parathyroid related tumors. And third P is pancreatic tumors, insulinoma, glucagonoma, gastrinoma kind of tumors. So, in men 1 syndrome, dekho guys, in men 1 syndrome, the patient can have parathyroid adenomas. Simple. What we have seen in this slide. Sir, in primary hyperparathyroidism, it's a hyperparathyroidism. Okay, more amount of parathyroid hormone. First thing, more amount of parathyroid hormone. Okay, what are the causes? Two causes I have give you: parathyroid adenomas, parathyroid hyperplasias. Why? Cyclin D1 overactivity, or it can be seen in men syndromes. Okay, it can be associated with men syndromes. Regarding men syndrome, what are the genes mutated? That we will discuss later. In men 1 syndrome, men 1 gene is mutated. That we will discuss later. Okay, which gland is going to be most commonly going to develop this parathyroid adenomas? Right inferior gland. Done. Now after this, what are the clinical features? If there is a person who is having hyperparathyroidism, more amount of parathyroid hormone. So what this parathyroid hormone is going to do, sir? It's going to increase the blood calcium level so much. So much. So first of all, in the labs, what you will see is parathyroid hormone levels are more, calcium levels are more. I have said you, parathyroid hormone is phosphate trashing hormone. So what happened to the phosphate levels in the body? So the phosphate levels in the body goes down because more excretion, parathyroid hormone excretes more phosphate out of the body. So in primary hyperparathyroidism, the patient is going to have elevated parathyroid hormone levels, elevated calcium levels, but less phosphate levels. Okay. So what are the clinical symptoms, sir? See, the clinical symptoms here are represented as bones, stones, groans and moans. Okay, the famous mnemonic, bones, stones, groans and moans. What is this bones referring to? Sir, in high quantities, I have explained you. In high quantities, parathyroid hormone causes osteoclastic activation, leading to bone resorption. So, painful bones. Okay, painful bones. The bones are undergoing destruction. Okay, there is bone resorption. So, this all problem is because of bone resorption by osteoclasts. Osteoclasts are doing bone resorption. So, what is happening, sir? The bones are getting brittle. So, there will be micro fractures that will happen in the bone. There will be micro fractures, sir. So, the bones are getting destroyed. The bones are getting damaged. So, there will be inflammation in the bones. So, osteitis. Okay. As there is damage that's happening in the bone, there will be hemorrhage that's going to happen. Okay. I will show you the images also. First, bones are getting damaged because of the excessive parathyroid hormone. As the bones are being damaged, so there will be little fractures and little hemorrhages also that is going to happen in the bone. So these hemorrhages are going to appear like a cyst. So cyst. Okay, osteitis. There will be cysts, and after that the bones are also going to heal, right? Bones are also tissues. The bone is being damaged. So after the bone destruction, so more scarring will be occurring. So fibrosis of the bones. Okay, fibrosis. So osteitis, inflammation of the bones. Cysts are going to be seen, hemorrhagic cysts are going to be seen, and there will be fibrosis. So this condition is called as osteitis fibrosa cystica. So osteitis fibrosa cystica, also called as brown tumor. Brown tumor, sir. Okay, it's not actually a tumor. It's nothing but the cysts. There is hemorrhage that's going to happen in the bone. I will show you the images later on. Okay, I will show you the images. Okay, so there will be hemorrhage that's going to happen in the bone. This is the bone tissue, normal healthy bone tissue. Okay. And see, there is hemorrhage. Here it is represented with hemocitrin. Hemorrhage is going to happen. Okay. So anyway, I will come to this area in a minute, but let me tell you. Sir, excessive amount of parathyroid hormone is going to cause more destruction of the bones. Destruction of the bones is going to cause osteitis fibrosa cystica. Done. Next, bones completed. After the bones, next stones. Sir, excessive calcium, what this calcium will do? So there is more calcium in the blood. The calcium will try to precipitate in the kidneys. The calcium is trying to precipitate in the kidneys and forming what? Kidney stones. So kidney stones, sir. Okay, so bones, stones completed. So this calcium will also deposit, okay, in the in the central nervous system. But here right now first let me discuss about the abdomen. Sir, what are the abdominal related problems here? The calcium is excessive amount of calcium. Okay, the excessive amount of calcium can lead to constipation, sir. This is the important point. Okay, the excessive amount of calcium will cause muscle spasms. Okay, and constipation. So groans. Okay, so because of this constipation, the patient can have groans, sir. So excessive calcium can cause groans. Okay, this is one thing. Nausea, vomiting, that's not that important. Next, psychiatric moans. What is this moans, sir? Okay, moans means, you know, right, the person unnecessarily making sounds. Okay, moans, psychiatric problems. Okay, moans, the making the sounds. So why moans? Why moans? Because the calcium is going to deposit in the central nervous system. Okay, the calcium is going to deposit in the central nervous system, leading to psychosis because of this calcium deposition in the basal ganglia, these regions. There can be psychosis, memory loss can occur, depression. Okay, so these are the central nervous system features. So what are the clinical features in a patient who is having hypercalcemia? If a patient is suffering with a hypercalcemia, that is primary hyperparathyroidism. In primary hyperparathyroidism, the patient can have hypercalcemia. So remember, the mnemonic which you need to know for your exams is, in primary hyperparathyroidism, the patient is going to have bones, moans, groans and moans. Okay, bones, groans, moans and stones. Okay, these things you can interchange, like change them anyway. So bone related problem is osteitis fibrosis cystica. Kidney related problem is the kidney stones. Abdomen related problem, main problem is the constipation, and psychiatric problems are going to be seen because of the calcium deposition in the central nervous system. So that's the moans, psychiatric moans. Depression can be there. Okay, there can be psychosis, like memory loss can be seen in this hypercalcemic conditions. Now, all these things you already know, just a recapping thing. So usually in the initial phases, okay, if there is little hypercalcemia, that's okay, asymptomatic. Little hypercalcemia, that's tolerable, asymptomatic. But in kidneys, in too much quantities, there will be nephrolithiasis, kidney stones, you know it. In GIT, I have explained you constipation. I have explained you about the constipation. Okay, now apart from constipation, see here I have written pancreatitis also. So why pancreatitis? You know, right? Calcium is enzyme activator. It's an enzyme activator. Okay, calcium is the enzyme activator. Normally in the pancreas, okay, if you look at the pancreas, the pancreatic enzymes, can you tell me some important pancreatic enzymes which are produced in inactive form? Inactive pancreatic enzymes, what are they? Trypsinogen, chymotrypsinogen and chymotrypsinogen. See, they are in inactive states. They are in an inactive state. Once they came into the duodenum, okay, there the trypsinogen will be converted into trypsin. Okay, once they come into the duodenum, in the duodenum, trypsinogen will be converted into trypsin with the help of enzymes like enterokinase. Okay, enterokinase, with the help of enzyme like enzyme called as enterokinase or entropeptidase, trypsinogen will be converted into trypsin. So the important point is, trypsinogen and chymotrypsinogen, they are produced in inactive form in the pancreas. But in the conditions where you are having hypercalcemia, that hypercalcemia, this calcium, excessive calcium, can activate these enzymes in the pancreas itself. Calcium is an enzyme activator. So within the pancreas itself, the trypsinogen is converted into trypsin, chymotrypsinogen is converted into chymotrypsin. Now what they will do? Now they will start to, the activated enzymes will start to first digest the pancreas, will cause the damage to the pancreas. So this is called as autodigestion of the pancreas, leading to pancreatitis. Okay. So if there is hypercalcemia, kidney stones, osteitis fibrosis cystica, just in the same way, in the GIT, constipation is there, okay sir, but can be also pancreatitis. Okay, there can be also pancreatitis. So peptic ulcer disease, okay, in a patient who is having hypercalcemia, lots and lots of calcium, there is a chance that he can develop the ulcers because of more acid production. Because of the more acid production, there is a chance that he can have more ulcers. So in the central nervous system, I have discussed central nervous system. It's a psychiatric moans, depression can be seen. Okay, memory loss can be seen. The same features. Okay, here also confusion, anxiety, memory loss, depression, same things. Okay, eyes, important sir, you don't know this. So eyes problem is, the calcium will start to deposit in the eyes, especially in the limbus region. So calcium deposition in the eyes can lead to band keratopathy, image based question which was asked, image based question. So what is this? Look here, there is a calcium deposition within the eyes is going to cause this banded appearance. This is called as a band keratopathy. Okay, band keratopathy. Okay, seen in hypercalcemic conditions like primary hyperparathyroidism. Okay, so deposition of calcium in the limbus region. Next, bones. You know the bones. What is the bone problem, sir? The bone problem is going to be osteitis fibrosa cystica. It is also called as brown tumor. Okay, brown tumor. So bones are getting damaged. The bone mineral density, the bones are getting damaged, sir. Bone resorption, excessive bone resorption. Whenever there is excessive bone resorption, osteoporosis is going to occur. Whenever there is osteoporosis, there is a chance that fractures can occur. Yes, so it's the vertebral compression fractures are the most common. Okay, so vertebral compression fractures are most common in osteoporosis. Okay, vertebral compression fractures, especially the lumbar vertebra. Okay, so the vertebral compression fractures that can be seen in primary hyperparathyroidism, hypercalcemia. Okay, so all the clinical features are completed. Bone problems, psychiatric problems, GIT problems, and what else? GIT problems, kidney problems, bone problems, and central nervous system problems. Bones, groans, stones, and bones. Okay, answer. So never forget about the pancreatitis, and image-based questions are also important. This is the band keratopathy. After this, look here. Now, sir, in this patient who is having primary hyperparathyroidism, this is also very important. Look here. Because of this excessive parathyroid hormone, what I have said you, bone resorption is going to occur. More and more the bones are getting destroyed. So you can see this, right? The bones are getting damaged. Okay, you can see these areas in the skull also that the bone is getting damaged. So this is called as salt and pepper skull. Okay, salt and pepper skull. So salt and pepper skull is seen in primary hyperparathyroidism because of the bone resorption, excessive bone resorption. And in the hands also, when you take the X-ray of the hands, what you can see is there is a concavity because of the excessive bone resorption. There is a concavity in the radial side. Okay, so there is a concavity on the radial side of the phalanges, on the radial side, towards the radial side. Okay, this is the side of the radius, right? This is the side of the radius. Towards the radial side of the phalanges, there will be excessive bone resorption that can be seen as concavity. Okay, so that's the one thing which I want you to know. Done. After this, so in X-rays, what you are seeing here, this is not a tumor, sir. Actually, it's looking like a tumor, right, in the bone. This is not actually a tumor. These are the hemorrhagic cysts. Okay, there is hemorrhage that's going to happen in the bones, forming the cysts. So these are brown tumors. These are called as brown tumors or osteitis fibrosa cystica. Okay, osteitis fibrosa cystica. This is actually the bleeding that's happening in the bone. Okay, hemorrhage. So done. So what is the laboratory diagnosis? How we can put the diagnosis? The diagnosis is serum parathyroid hormone levels are elevated, serum calcium levels are also elevated, but look at the serum phosphate levels. The serum phosphate levels are damn low. Serum phosphate levels are less. Why? Because it is primary hyperparathyroidism, PTH, phosphate trashing hormone. Phosphate is going out of the body, phosphate levels are less. Okay? Answer. Now, here as a just integration, I am just putting this. What are the other conditions in which the serum calcium levels are going to be elevated? The primary hyperparathyroidism, because of that parathyroid adenoma or because of parathyroid hyperplasia, you can have high amount of parathyroid hormone, high amount of calcium levels. Okay, done. But what are the other conditions in which the calcium levels can be elevated? Drugs, certain drugs can increase the blood calcium levels. Thiazide diuretics increase the blood calcium levels. Sarcoidosis, which I want you to know is this. Sarcoidosis are very important. Okay, sarcoidosis. And certain cancers, especially multiple myeloma, it's a cancer, sir. Squamous cell carcinoma of the lung, breast carcinoma, renal carcinoma. So these are the cancers which are I want you to know very much. In multiple myeloma conditions and SCC, squamous cell carcinoma of the lung, breast carcinoma, and renal cell carcinoma. So these conditions are associated with the elevated calcium levels in the body. Okay, just for this one thing, I'm keeping this, and for sarcoidosis also very important. In sarcoidosis also the calcium levels are elevated in the blood. Okay, so after this, let me discuss about primary is done, sir. Primary is done. Primary hyperparathyroidism is completed, which means that there is some problem in the parathyroid glands, adenoma or hyperplasia, that's causing excessive amount of parathyroid hormone secretion. Done, sir. See, what is the secondary hyperparathyroidism? Secondary hyperparathyroidism means there is some secondary cause, some other cause is there in the body, some other cause is there that is leading to elevated parathyroid hormone levels. Okay, there is some secondary cause. Let me write here. There is secondary cause. This secondary cause is leading to increased parathyroid hormone secretion. Okay, so what is the secondary cause, sir, if you ask me? The secondary cause is renal failure. Okay, renal failure, sir. Done. So kidney problem, renal failure, chronic kidney disease, renal failure. Now, tell me, Sir, what is the function of the kidneys? Normal function of the kidneys, sir. The function of kidneys is calcium reabsorption. Okay, calcium reabsorption. Normally, calcium will be reabsorbed in the kidneys. And activation of vitamin D. What vitamin D will do? Sir, vitamin D in the kidneys, vitamin D is activated. What vitamin D will do? Vitamin D increases the blood calcium levels. Increase the blood calcium levels. Vitamin D increases the blood calcium levels. Now tell me, kidney, if it is gone, sir. Now, do you think calcium reabsorption is going to occur? No, calcium reabsorption is not going to occur. So calcium loss in the urine, sir. The calcium is going to be lost in the urine. Calcium loss. And do you think vitamin D is going to be activated? No, this is the very, very important MCQ. Vitamin D activation not there, blood calcium levels are not going to be maintained. So there is now hypocalcemia. Now there is hypocalcemia in the body. This hypocalcemia is activating the parathyroid glands. It is activating the parathyroid glands. Okay, parathyroid glands. Okay, so then here the parathyroid glands are absolutely normal. Kidney failure, no vitamin D, so blood levels of calcium is going down. As the blood levels of calcium is going down, now parathyroid glands are going to produce excessive amount of parathyroid hormone. Why excessive amount of parathyroid hormone? Why? Because see, whatever this parathyroid hormone is going to do, till at the end of the day kidney is not there. Calcium is lost out of the urine. Okay, calcium is not going to stay in the blood. Okay, so simply remember like that. See, in primary hyperparathyroidism, how to differentiate between primary and secondary? See, both in primary and secondary, okay, let me just show you here. Here. Both in primary and secondary, the parathyroid hormone levels are elevated, no doubt. But in primary, the calcium levels are elevated. But in secondary, calcium levels are less. Kidney problem. All the calcium is going out of the body. Parathyroid hormone will try to increase the calcium, but the calcium will go out of the body. Calcium is not staying. Okay, so remember like that. So in secondary, let me tell you, the problem here is the vitamin D activation not there. Vitamin D is not getting activated. Okay, remember that thing. And there will be renal osteodystrophy. Renal osteodystrophy. Why the word renal osteodystrophy? Because it's very clear. There is some renal problem. So because of this renal problem, the calcium levels are decreasing in the body. Parathyroid glands are getting activated. The parathyroid glands produces more parathyroid hormone. What parathyroid hormone will do? Parathyroid hormone, what it will do? Parathyroid hormone causes the bone destruction. Whenever there is bone destruction, what happens? There is osteodystrophy, bone damage, osteodystrophy. So it's the renal problem which is leading to the bone problem. So usually in your future you will understand that patient who is having renal failure, the patient who is having the renal failure, he will have secondary hyperparathyroidism which will cause the bone destruction. So if you look at, this is the image based question which was asked many times in like board exams as well as Indian exams. See, these are the vertebra, right? These are the vertebra. Now what you will see here is, so this is called as a rugger jersey spine. See, in the body of the vertebra, you can see this lucency, okay, the black color area. So it's looking like white band and black band, white, black, white, black, white, black. So this is called as rugger jersey spine. So rugger jersey spine, it is seen in hyperparathyroidism, okay, but especially seen in the secondary hyperparathyroidism, secondary to renal disease or kidney failure. Okay, so this is called as the rugger jersey spine. Now, what about the parathyroid hormone levels? Elevated, sir. What about the blood calcium levels? Even though parathyroid hormone is there, the blood calcium levels are still decreased. X-ray shows rugger jersey spine. Okay, so these are some important points which I want you to know, how to differentiate between primary and secondary hyperparathyroidism. Okay, now, so you understood, right? Primary and secondary hyperparathyroidism, how to differentiate? Say primary hyper, secondary hyper. What is the difference? In clinical setup you can understand. Kidney failure patient developing the problems, it is secondary hyperparathyroidism. Okay, but labs, parathyroid hormone is elevated in both the conditions. Blood calcium levels and phosphate levels. So what about the calcium levels? So the calcium levels in primary hyperthyroidism is more. Okay, primary hyperparathyroidism is more. and in secondary hyperparathyroidism it is less. Phosphate levels in both the conditions, parathyroid hormone is more. So what happens? Phosphates will be excreted, sir. Okay, so in both the conditions, phosphate levels are going to be less. Okay, done. Now, after this, hyper completed, sir. Hyperparathyroidism is completed. Now let's discuss about the hypoparathyroidism. Hypo means what? Less amount of parathyroid hormone. Why there is less parathyroid hormone? Why? Why, sir? The most common cause is surgical removal. Okay, during surgery to the thyroid gland. Okay, during surgery to the thyroid gland, by mistake, the parathyroid gland is removed. But these days this is not happening. These days surgeons are going to be so much precise that they know what they are removing. Okay, what actually happens, to be really frank, what actually happens is, while they are doing surgery to the thyroid gland, they will disrupt the blood supply to the parathyroid gland. They will cause the disruption of the blood supply. As there is disruption in the blood supply, that can lead to hypoparathyroidism. It's not just the surgical removal of the gland. Exactly, to be very precise, it's the disruption of the blood supply to the parathyroid glands will lead to hypoparathyroidism. Okay, so don't forget about that. But generally in most of the books it mentions most common cause is surgical removal. But you know, it's not just the surgical removal, surgical disruption of the blood supply. Okay, so surgical removal in developing countries, and most common cause in Western countries, already developed countries. Okay, most common cause is autoimmune destruction. Okay, autoimmune destruction means autoantibodies are destroying the parathyroid glands. Autoantibodies are destroying the parathyroid glands, right? So what are the two causes of hypoparathyroidism? The two causes. Okay, the two causes can be surgical, during surgery damaged, okay, or autoimmune destruction of the parathyroid glands. Hypoparathyroidism can also be seen in Dysart syndrome. Hypoparathyroidism can be also be seen in Dysart syndrome. Sir, Dysart syndrome. Sir, what is this Dysart syndrome? Sir, in this Dysart syndrome, there is a deletion of certain genes. Deletion of 22q11.2. 22q11.2. That's a genes. That's the gene locus. Okay. So there is a deletion of these genes. So because of the deletion of these genes, from birth itself, these genes are not there. So there is absence of third and fourth pharyngeal pouches. Okay, there is absence. Okay, there is not developed, sir, hypoplasia, not developed. So the hypoplasia of third and fourth pharyngeal pouches. Third and fourth pharyngeal pouches are not developed. Okay. So Dysart syndrome, it's a deletion of, okay, it's a deletion of 22q 11.2. Third and fourth pharyngeal pouches are not developed. Now I have explained you. It's the third and fourth pharyngeal pouch. From the fourth pharyngeal pouch, superior parathyroid glands. Third pharyngeal pouch gives rise to inferior parathyroid glands. We have discussed. So as the third and fourth pharyngeal pouches are not developed, there is hypoplasia of, so you can write absence, simple, not developed, absence of parathyroid glands. Parathyroid glands are not developed. And even thymus is not developed. Why I am telling you? Because I have explained you. Third pharyngeal pouch, don't forget. Okay, so look here, it is the third pharyngeal pouch. Third pouch will give rise to thymus also. So now in this condition, fourth is not there, third is not there. So inferior parathyroid gland, superior parathyroid gland and thymus are not going to form. Okay, so these patients with the Dysart syndrome, what kind of symptoms they are going to suffer with? So these patients with the Dysart syndrome, they are going to suffer with thymic aplasia. Thymus is not there. Okay, thymic aplasia. As a thymus is not there, thymus is the site where T lymphocytes are going to mature. So in this patient, the T lymphocyte proper maturation is not going to occur. So when the T lymphocyte proper maturation is not there, so this patient can have recurrent infections. Okay, these patients can have recurrent infections. The parathyroid glands are not there. When the parathyroid glands are not there, what happened to the blood calcium levels? The blood calcium levels will decrease. Okay, the blood calcium levels will decrease. Hypocalcemia. The patient is now having hypocalcemia with recurrent infections. Dysart syndrome. Deletion of 22q 11.2. Absence of third and fourth pharyngeal pouch as well as thymic aplasia. And hypomagnesemia. What are the other causes, sir? What are the other causes of hypoparathyroidism? One cause, surgical damage. Second cause, autoimmune destruction. Third cause, Dye-George syndrome. Fourth cause, hypomagnesemia. So magnesium is very much important. Just I used to remember something like this. So magnesium, it is very much important for the production of parathyroid hormone. If magnesium is not there, parathyroid hormone is not there. Simple as that. So magnesium is very much important for the production of parathyroid hormone. Hypomagnesemia, hypoparathyroidism. That's it. Okay, 4 causes I have explained you. Okay, 4 causes I have explained you. Okay, so what are the clinical features, sir? The clinical features, if you are having hypocalcemia, let me write here, hypocalcemia, what are the clinical features that are going to be seen? So you should know, take a note, normally our neurons, the excitability of the neurons is, most of the students will think, sir, calcium is responsible for excitability. No. Okay, it's the sodium which is responsible for the excitability. Calcium decreases the excitement of the neurons. Remember, calcium decreases, remember, very important, decreases the excitement of neurons. Okay, in nerve physiology, I hope you have studied this. Calcium will inhibit the overactivity of the neurons. Whenever the calcium is going down, okay, whenever the calcium is not there, so what happens, sir? Okay, hypocalcemia. Whenever there is hypocalcemia, neurons, what they will do? They will hyperexcite. Okay, over-excitation. So there is, whenever the neurons, whenever they are overexciting, whenever the neurons are overexciting, these alpha motor neurons, whenever they are overexciting, what happens to the muscles? There is excessive contractions. Excessive contractions. That's called as tetany. Okay, that's going to be called as tetany, sir. So hypocalcemia will lead to tetany. Okay, hypocalcemia will lead to tetany. Hypocalcemia, more excitation of the neurons, more muscle contraction, leading to tetany. Okay, leading to tetany, sir. Okay. Now, how can we know that the patient is having hypocalcemia? How can we know that the patient is having hypocalcemia, sir? By doing certain physical tests. By doing certain physical examination, we can say this fellow is having hypocalcemia. How? Just take this person and just tap on his face. Okay, don't slap, just tap on the parotid gland. You know the parotid gland, right? So in the inferior border of the parotid gland, just make a tap. So whenever you are tapping, if the patient is having hypocalcemia, then there will be unilateral contractions. There will be unilateral contractions. That is called as Chvostek sign. Okay, that's called as Chvostek sign. Tapping will cause unilateral contractions, facial contractions. This is called as Chvostek sign. So, what you will find on physical examination? Physical examination findings. One is Chvostek sign, and so next thing is, so when you try to measure the BP of this patient, okay, he came to you generally. Usually, we doctors, what we will do? We will just go for the normal BP checkup, right? The nurse is going to take the BP. So when the nurse is increasing the pressure in this BP cuff, so what actually happens is, if the patient is having hypocalcemia, immediately the muscles will contract. Okay, immediately the muscles will contract. So this is called as carpopedal spasm. Okay, carpopedal spasm. So that is called as Troussier sign. So what are the two signs which are seen? One is the Chvostek sign. It's a sign of hypocalcemia, and other is the Troussier sign. It's a carpopedal spasm on increasing the pressure in the BP cuff. When you are increasing the pressure in the BP cuff, it will cause spasm. Okay, so Chvostek sign and Troussier sign. Now, how can we put the diagnosis? Simple. It's a hypoparathyroidism, right? Hypo. So parathyroid hormone levels are less. Calcium levels are also less. Okay, so parathyroid hormone levels are less. Calcium levels are also less. Phosphate levels. What happened to the phosphate levels? Phosphate levels will be more. Okay, parathyroid hormone is opposite to phosphate. Okay, simple as that. So completed, sir. Okay, hypoparathyroidism is completed. Okay, hypoparathyroidism is completed. Now after this, hypoparathyroidism. Actually, there are other types of hypoparathyroidism also, like a secondary hypoparathyroidism. Okay, pseudo hypoparathyroidism. Okay, so that's called as a pseudo hypoparathyroidism. Yeah, they are important. Okay, let me tell you why to leave it. So let me tell you about the pseudo hypoparathyroidism also now itself. Okay, This will be very much important for the exam going batches. Okay, as you guys are not going for any direct exam, but anyway, let me tell you what is pseudo hypoparathyroidism, sir. In the name itself, it's there. Pseudo means false. Falsely, it is looking like there is hypoparathyroidism. What is the problem? It's the end organ resistance. Okay, it's the end organ resistance. Means parathyroid hormone is there. Parathyroid hormone is there, but the tissues like bones and kidneys. Okay, so it's the kidneys and bones. They are not receptive. They are not receptive. They are not welcoming the parathyroid hormone. So parathyroid hormone is there, sir, no problem. But the kidneys and bones are not responding to the parathyroid hormone. As they are not responding to the parathyroid hormone, what happened to the blood calcium levels? Will be less. So parathyroid hormone is there, but still the blood calcium levels are going to be less. Why? Because kidneys are not responding, bones are not responding. Simple as that. Okay, so no vitamin D activation, no calcium reabsorption. Okay, no calcium absorption. Nothing is going to happen. Okay, so there is end organ resistance. This is important. End organ resistance. Why? See, it's observed that in these patients who are having pseudo hypoparathyroidism, gene as, okay, so gene mutations are seen. Okay, gene mutations are seen. Even in yesterday's class, thyroid also we have discussed. Gene as gene mutations are seen with toxic adenomas, toxic adenoma of the thyroid gland. In yesterday's class I have discussed. Okay, next, what are the clinical features? Same clinical features, sir. Same clinical features, similar to hypoparathyroidism, but this problem is there from the birth itself. This problem is there from the birth itself. Okay, end organ receptor mutation. As the problem is there from the birth itself, the bone formation is not properly happening in this baby. So as the problem persists since the birth, baby will have rickets. Baby will have rickets. Why? Because the blood calcium levels are less. Vitamin D is not there. Parathyroid hormone is not there. I should say parathyroid hormone is there, but it is not functional. It is not able to activate the kidneys as well as the bones. So there is rickets from the birth. So this is called as Albert osteodystrophy. MCQ. This is the MCQ. Arey, kya hai? What is Albert osteodystrophy? Albert's osteodystrophy is it's a bone problem. Say osteodystrophy. Seen in pseudo hypoparathyroidism. Parathyroid hormone is there, but it is not able to activate the kidneys and bones. And as simple as that. Okay. So what are the clinical features? Same clinical features, sir. All same clinical features. Okay. So hypocalcemia means tetany is going to be there. Okay, hypocalcemia means tetany is going to be there. Chevostic sign, Trousseau sign, these things are going to be there. Bone formation is bone formation is not going to happen properly. But here one important thing, sir. In this Albert osteodystrophy, which is there from the birth, in this Albert osteodystrophy, look at these hands. These are the knuckles, right? We say these are the knuckles. Okay, knuckles. So the fourth and fifth metacarpals are not developed. Okay, the fourth and these are the metacarpals, first metacarpal, second, third, fourth, fifth. See, the fourth and fifth metacarpals, they are going to be short, not properly developed. Okay, as they are not properly developed, if you ask this patient to have his fist like this, you can see my knuckles, right? These knuckles are because of what? These are the metacarpals. Okay, metacarpals. So first, this is the first metacarpal, second, third. This fourth and fifth metacarpals are not going to be properly developed, short metacarpals. So you cannot see these knuckles. So this is called as knuckle dimple sign. So here you can see the knuckle, here also you can see the knuckle, but here you cannot see any knuckles. So that's a dimple, there is no knuckle. So there is a knuckle dimple sign. So knuckle dimple sign is seen in pseudo hypoparathyroidism or Albert's osteodystrophy. Simple. Okay. So short stature. See, these are all the clinical features of Albert's osteodystrophy, which is there from the birth. Seen in which condition? Pseudo hypoparathyroidism. So calcium is not there. Parathyroid hormone is there. Remember, parathyroid hormone is there, but calcium is not there. So short stature. As the calcium is not there, over-excitation of the neurons can lead to tetany. So look here, the muscles are getting contracted, so much contracted. Okay, this is seen in hypocalcemia, not just in Albert's dystrophy. It's seen in everyone who is having severe hypocalcemia. So see how it's not. Previously, the people used to thought that the person is possessed with some devil. This is not some, like, the patient is not possessed with any devil, sir. It's actually the muscle contraction, excessive muscle contraction is causing this position, which is called as opisthotonous position. Okay, opisthotonous position. Okay, so tetany is going to be there, short stature, the deposition of the, there can be mental retardation. Okay, even this patient, there can be mental retardation. There can be archibald sign or knuckle dimple sign. Okay, archibald sign or knuckle dimple sign. Okay, so these are the things which I want you to know. So what are the labs? How the labs are going to be? In pseudo hypoparathyroidism, very much important. The parathyroid hormone is there. So if you look at the parathyroid hormone levels, actually there are more parathyroid hormones, sir. Parathyroid hormone is there, but it is not able to activate. Okay, so calcium levels are less. Forget about this alkaline phosphatase, it will be normal. In pseudo hypoparathyroidism, parathyroid hormones are there. Parathyroid hormone is even elevated MCQ because it's unable to activate. So more and more parathyroid hormone is producing. Okay, but falsely it is looking like hypoparathyroidism, non-functional PTH. Okay, so done, sir. Okay, so regarding parathyroid, I have discussed. Important is knuckle dimple sign, Rugger jersey spine. Okay, image based question. Just as a recap, opisthotonous position seen in hypocalcemia, severe hypocalcemia, tetany, knuckle dimple sign, Albert's osteodystrophy. Okay, next Chevostic sign, Krause sign. Okay, next Rugger jersey spine seen in secondary hyperparathyroidism. Okay, you can see osteitis fibrosa cystica, brown tumors. Okay, osteitis fibrosa cystica. This is salt and pepper appearance of the skull seen in primary hyperparathyroidism. Here you can see the concavity in the radial side of the bones, and keratopathy. Okay, all these are the image based questions which are needed for your exams. Done, sir. Now after this, okay, let's discuss about the adrenal disorders from here. The topics will be like, very easy, simple. Now what is this? So this is your adrenal gland, TK. Now adrenal gland is made up of adrenal cortex as well as adrenal medulla. Now what is the problem here? Tell me. What is the problem here? There is a tumor in the adrenal gland cortex. A tumor in the adrenal gland cortex. This is called as adrenal adenoma. This is called as what? Adrenal adenoma, sir. Where is it present? It's present in the cortex, not in the medulla. Now this adrenal adenoma, do you know what it will do? The stupid tumor is going to produce excessive amount of aldosterone. Okay, steroid. It's going to produce excessive amount of aldosterone. Okay. So now tell me, what is the name of this syndrome? So this adrenal adenoma producing excessive amount of aldosterone. It is called as which syndrome? Do you have any idea? The name of the syndrome is called as Conn syndrome. Okay, the name of the syndrome is called as Conn syndrome. Now tell me, what is the normal function of aldosterone? Normally, aldosterone hai. Mineralocorticoid, aldosterone is called as mineralocorticoid, sir, you know it, right? Now, whenever there is excessive amount of aldosterone, what happened to the sodium reabsorption? Normal aldosterone helps in, see, let me write here the normal functions. Okay, normal function of aldosterone. What are the normal functions of the aldosterone, sir? 3 functions are there. One is increases the sodium reabsorption, increases the potassium and proton excretion in urine. Okay, the normal functions of aldosterone, the 3 functions of aldosterone is aldosterone increases the sodium reabsorption, increases the potassium and proton excretion. Okay, excretions. But imagine now we are having Conn syndrome where the aldosterone levels are going to be super high. There is so much amount of aldosterone. What happens? So much sodium is going to be reabsorbed, right? So what are the clinical features? The clinical features are going to be hypernatremia. More sodium is getting reabsorbed. So that causes hypertension. More sodium means hypertension, sir. The patient is now having clinical features like hypertension. Okay, hypertension. Second, so the potassium and proton are going out of the body. More potassium excretion, more proton excretion. So as the more and more potassium is going out of the body, that will cause hypokalemia and alkalosis. protons are going out, more protons are excreted. So alkalosis, more potassium is going out. So hypokalemia. Okay. So this hypertension is because of more sodium. So more sodium reabsorption. Hypertension, less potassium is there in the body. More potassium is going out. So hypokalemia and metabolic alkalosis. So these are the clinical features which are seen in Conn syndrome. Conn syndrome. So Conn syndrome completed. Now after Conn syndrome, the next syndrome that I want to discuss here is called as a pheochromocytoma. Pheochromocytoma. So what exactly is this pheochromocytoma? Quickly, what exactly is pheochromocytoma and what you should know for your exam? Especially this is important for the board exam, sir. I will show you some histological pictures also. Sir, look here. This is your cute little adrenal gland. This is your adrenal gland. Now, in the adrenal gland, what is this central region called as? This is called as adrenal medulla. Adrenal medulla. Okay, adrenal medulla. So this adrenal medulla, it is made up of which cells? Do you know? Do you have any idea? This adrenal medulla is made up of which cells, sir? Sir, it's made up of chromaffin. Chromaffin cells. It's made up of chromaffin cells. Now, if you are having a tumor here, see, previously I have discussed there is a tumor in the adrenal cortex. If there is a tumor in the adrenal cortex, it is called as Conn syndrome. If there is a tumor here, okay, if there is a tumor here in the adrenal medulla, then it is called as this tumor. My God, this tumor, it is called as pheochromocytoma. Okay, pheochromocytoma. So now tell me, so these pheochromocytomas, what they will produce? What they will release? Aldosterone, cortisol, testosterone? No. Adrenal medulla produces epinephrine, norepinephrine, adrenaline, noradrenaline. Adrenal gland produces adrenaline. Cortex and medulla. So these chromaffin cells normally produces adrenaline, noradrenaline. Now there is a tumor. Now as there is a tumor, what they will do? They will produce excessive amount of, okay, now they will produce excessive amount of epinephrine and norepinephrine. Okay, they will produce excessive amount of epinephrine and norepinephrine. So what are the clinical features that are going to be seen? So the clinical features are going to be, sir, they are sympathetic hormones, right? Epinephrine, norepinephrine, they are the sympathetic hormones. As they are sympathetic hormones, what are the clinical features? Sympathetic features are going to be seen. More sympathetic features are there in the body. What are they? Hypertension. Hypertension, sir. Sympathetic hormones will cause increase in the BP. Hypertension. Whenever there is hypertension, there is headache, nausea, vomiting. So let me see here what are the clinical features. The clinical features are going to be excessive levels of catecholamine, going to cause hypertension. That hypertension can lead to headache. Sympathetic features, more sweating, sympathetic feature. Okay. Sympathetic nervous system, sympathetic hormones increases the heart rate. So that's why here also in pheochromocytoma, there is palpitations and tachycardia. Sympathetic nervous system activates your central nervous system, excites the neurons. So anxiety. Okay, anxiety. Okay, so these are the important clinical features I want you to know. Yes, of course, weight loss is going to be there. It's a long-term thing. Okay, but important point is hypertension, tachycardia, more BP. Okay, headaches are going to be seen. Okay, so these are the sweating, palpitations. All these are the features of pheochromocytoma. Okay. Now let's answer one by one. Okay, these are the questions which were previously asked. Now look at here. Pheochromocytoma. It's the tumor of which cells? That's a tumor of chromaffin cells. It's a tumor of chromaffin cells in adrenal cortex or adrenal medulla. In the adrenal cortex, sorry, in the adrenal medulla, sir. In the adrenal medulla. See, not only in adrenal medulla. See, look, you should understand. Sir, these chromaffin cells are there. No, they are present in other places also, sir. The chromaffin cells, they are present in other places in the body also, like in sympathetic ganglia. In some places, in certain places, they are present, sir. So if you have tumor of chromaffin cells outside the adrenal gland, see, look, it's a tumor of chromaffin cells outside the adrenal gland, that is extra-adrenal pheochromocytoma. Extra-adrenal pheochromocytomas are called as paragangliomas. See, they go extra-adrenal pheochromocytomas are called as paragangliomas. MCQ. So paragangliomas are nothing but the tumor of chromaffin cells, but not in the kidney, outside. Extra-adrenal pheochromocytomas are called as paragangliomas. So these paragangliomas, they will produce Okay, they will produce norepinephrine only. Okay, they will produce norepinephrine only. Okay, no epinephrine, norepinephrine only, so predominantly. Okay, done. So after this, what I should teach you, some other extra points I should teach you. Look here, they go one by one. It's a tumor of chromaffin cells in the medulla. Okay, what is the most common site? Yes, adrenal medulla is the most common site. What they will secrete? Norepinephrine, also epinephrine, true. Okay, so this extra adrenal pheochromocytomas are called as paragangliomas. Just now I have discussed. They are associated with, now question, MCQ. The pheochromocytomas, they are associated with which syndrome? Men syndrome. Last, at the end of this class, I will explain you about the men syndromes. Sir, pheochromocytomas are seen in men type 2. Okay, just wait. I will show you now itself if you want. Sir, look here. In men type 2, men 2A and 2B. What you are seeing, sir? Pheochromocytoma. Okay, pheochromocytoma. So, pheochromocytomas are associated with men type 2. Okay, associated with men type 2, sir. Pheochromocytomas. Okay, men type 2. Okay, not only men type 2, Von Hippel-Lindau syndrome. Okay, Von Hippel-Lindau syndrome. Sir, in men type 2, pheochromocytomas are seen. Von Hippel-Lindau syndrome also, pheochromocytomas are seen. Neurofibromatosis type 1, pheochromocytomas are seen. And Sturge-Weber syndrome. This is the MCQ. Pheochromocytomas are seen in all of the following conditions except. Pheochromocytomas are seen in Sturge-Weber syndrome, true. Neurofibromatosis, true. Von Hippel-Lindau syndrome, true. Men type 2, true. Okay, so these are the points which I want you to know. So pheochromocytomas, they follow the rule of 10. Okay, they follow. They are like, little discipline. They follow some rules. What is this rule of 10, sir? I used to remember something like this, just like, a funny mnemonic which I made it for myself. So, these pheochromocytomas, 10%, okay, 10% of the time, 10% are extra adrenal, that is paragangliomas. 10% of the time, they occur as paragangliomas. 10% of the time, they are seen in both the kidney, both adrenal glands, bilateral. 10% of the time, they are familial. See, these are the, familial conditions. They are familial, passing in the families via the genes. And 10% of the time, they will turn into cancer, malignant. 10% will be multiple, okay, multiple are seen, not just one tumor, multiple tumors are seen. And 10% of the time, they are seen in children. Okay, so I used to remember like extra BF. BF means like, boyfriends kind of thing, right? Extra boyfriends are malignant. Do you know why? They causes multiple children. Okay, more boyfriends, more children, something like that. Okay, so what exactly I mean by here? Okay, what exactly I mean by here is this pheochromocytomas follows the rule of 10. 10% of the time they are extra-adrenal, bilateral, seen in children, turn into cancer. Okay, you know it anyway. Okay, bilateral, you know it, right? So they follow rule of 10. So how to put the diagnosis, sir? How to put the diagnosis? See, this is the adrenal gland. This is the adrenal cortex. Now, where is the tumor present, sir? Here is the tumor, pheochromocytoma. Okay, here is the tumor, sir. Now, what this tumor is going to produce? So, this tumor is going to produce norepinephrine. They will do the duty, norepinephrine. They will cause all the unnecessary symptoms in the body, tachycardia, palpitation, sweating, all the things, headaches, increase BP, hypertension. Okay, but at the end of the day, once norepinephrine is there, do you think the norepinephrine is going to be there throughout the day? No. The norepinephrine is going to be metabolized where? In the liver. And epinephrine is going to be metabolized in the liver. So, into what? Into the degradation products, metabolites. So, they are vinyl mandelic acid. So, vinyl mandelic acid, that is VMA, VAMA. Okay, I used to remember like VMA. So, vinyl mandelic acid levels and second one, the degradation product, the second degradation product of this catecholamine, second degradation product in the liver, it is called as metanephrine. Okay, so metanephrines. So these are the degradation products. Now the epinephrine, norepinephrine are going to be converted into vinyl mandelic acid and metanephrines. Now where they will come out, sir? So where they are there, they will come out in the urine. They will come out in the urine. So in the urine, the vinyl mandelic acid levels, especially important. The most sensitive is the metanephrine levels. They will be very high. So just collect a urine sample, and if you look in the urine sample, the vinyl mandelic acid levels and the metanephrine, especially metanephrine levels are going to be super high. So based on the urine examination, you can put the diagnosis, this fellow is having pheochromocytoma. Okay, so that's the important point which I want you to know. So what are the diagnostic tests? The diagnostic tests: collect the urine and check for metanephrine levels. Okay, total metanephrine levels, that's a very important thing. Okay, also vinyl mandelic acid levels will be elevated. Okay, so these are the some important points which I want you to know. So pheochromocytoma completed, sir. Like the pheochromocytoma in the sense the general points are completed. Pheochromocytoma. What else you should know is, so there are multiple genes. Dekho, pheochromocytoma, PCC, pheochromocytoma. Okay, pheochromocytoma, paragangliomas. Both are almost the same things, right? Pheochromocytoma, paraganglioma, based on the location. In your exams, this question can be asked. Okay, these pheochromocytomas or paragangliomas are due to which gene mutations? What are the gene mutations which can lead to this pheochromocytoma? Syndromes which are associated. See, what are the syndromes which are associated with the pheochromocytomas? Wen type 2, von Hippel-Lindau syndrome, neurofibromatosis type 1, Sturge-Weber syndrome, you know it, right? But what are the gene mutations which can lead to pheochromocytomas? Here are the gene mutations. Red gene mutation, von Hippel-Lindau gene mutation, neurofibromatosis type 1 gene mutation, succinate dehydrogenase gene mutations. Okay, so here I have given a list. Don't go through this table unnecessarily. Dekho, gene mutations causing pheochromocytomas: red gene, von Hippel-Lindau gene, neurofibromatosis type 1 gene mutation, and succinate dehydrogenase gene mutation. Okay, succinate dehydrogenase gene mutation. So these are the gene mutations which can lead to pheochromocytomas. Okay, pheochromocytomas gene mutations will lead to the tumors. After this, see, under the microscopy, okay, take a pheochromocytoma, take a biopsy and put it under the microscope and you look at the histology. If you look at the histology, what you will see is Zellballen pattern is seen. Okay, Zellballen pattern. So what the hell is this Zellballen pattern? Okay, what is this Zellballen pattern? See, Zellballen means in German, it means a ball of cells. Like a ball which is made up of cells. So this Zellballen pattern, it is seen in pheochromocytoma. Okay, he is a scientist. Okay, who have first coined the the term the Zellballen pattern. Okay, so what is this Zellballen? It's the arrangement of the chromaffin cells in the form of nests, in the form of balls. That is called as a Zellballen pattern. Okay. Now these tumor cells, they are also surrounded by, sustentacular cells. Okay, sustentacular cells. I will show you in the histology. The tumor cells, yes, they are arranged in the balls. Okay, they are arranged in the form of balls. The balls, these are made up of this chromaffin cells. Okay, but these tumor cells, they are also surrounded by cells called as sustentacular cells. Okay, now you look at the histology. Okay, you can look at the histology. Now look here. This is the pheochromocytoma. Sir, here in the pheochromocytoma, are you able to appreciate these tumor cells? They are arranging in the form of balls. Okay, they are arranging in the form of balls. And here you can see the sustentacular cells. Okay, here also, these are the tumor cells. Here, dekho, this is the sustentacular cells. Sir. These are the ball of cells where you can see the sustentacular cells. Okay, here also, dekho. The tumor cells are arranging in the form of balls surrounded by the sustentacular cells. Okay, now MCQ which was asked. So when you stain these cells, immunohistochemistry, when you go for the immunohistochemistry, not just hematoxylin and eosin stain, this is a H&E stain, hematoxylin and eosin stain. But when you go for the immunohistochemistry, what you will see? What will be coming positive? Sir, in pheochromocytoma, synaptophysin positivity will be seen. Chromogranin positivity will be seen. Non-specific esterase positivity. S100 positivity is going to be seen. Why? Because see, the synaptophysin, synaptogranin, sir, these are going to be positive in cells with neural crest cell in origin or neuroendocrine in origin. Okay, usually the synaptophysin, chromogranin, where they are present, sir? Where they are present? Sir, these are the proteins which are present in the cells which are derived, which are neuroendocrine cells. Okay, which are neuroendocrine cells. So here our pheochromocytoma, the chromaffin cells are also neuroendocrine cells. Okay, they are also neuroendocrine cells. So that's why as these cells are neuroendocrine cells, see, the chromaffin cells are neuroendocrine cells. That's why in this neuroendocrine cells, you can see the synaptophysin, synaptophysin and chromogranin, synaptophysin, chromogranin and non-specific esterase positivity and S100 positivity. They are going to be seen, sir. Okay, so you can look here. This is the histology. See, you can still look here the Zellbalan pattern. Okay, Zellbalan pattern. Now, what is this A, B, C and D representing? See, the histology, modern histology of the pheochromocytoma. First A is hematoxylin and eosin stain. This is normal H and E stain, pink and blues. Okay, H and E. Next B to D. The B to D. So B, D, B, C and D. That's the immunohistochemistry. We have done the immunohistochemistry. Okay, using chromogranin, synaptophysin and S100 positivity. Okay, here you can see the sustentacular cells. They are having this S100 positivity. Okay, they are taking this. Okay, so synaptophysin, chromogranin, non-specific esterase positive and S100 positivity is in. Simply in your exam, only what they will ask you is histology, Zellbalan pattern. Okay, Zellbalan pattern. The tumor cells are surrounded by sustentacular cells. Immunohistochemistry will come positive for synaptophysin, chromogranin, non-specific esterase and S100 positivity. Done. After this, what else you should know is, sir, this is the adrenal gland, this is the tumor, this is the pheochromocytoma. Okay, this is the pheochromocytoma. This is a tumor, sir. Dekho. This is the tumor in the adrenal gland, this is the pheochromocytoma. Now see how it is like a pink color, pink, okay, pink to reddish in color, that's okay. But when you put potassium dichromate here, okay, now you are applying, you have taken the tumor, you have made a cross section, you have chopped it into two parts. Now you have taken potassium dichromate and you are applying the potassium dichromate here. Now immediately do you know what happens? The tumor is going to turn into brown color. Okay, this pheochromocytoma is going to turn into brown color, sir. Do you know why? So this reaction is called as chromaffin reaction. Okay, this reaction is called as, okay, this is the tumor, see how it is turning into this brown to almost blackish in color. This reaction is called as chromaffin reaction. Why chromaffin reaction? Here the explanation is given. Look guys, look here. See, the freshly cut tumor surface turns brown. The freshly cut tumor surface turns brown when immersed with potassium dichromate solution. Why? Because it's a pheochromocytoma. Inside the pheochromocytoma, what do we have? Epinephrine, norepinephrine is there. So this potassium dichromate reacts with this epinephrine, norepinephrine. Dekho, see, this is due to oxidation of stored catecholamines. Already catecholamines is there. Now when you put potassium dichromate, the stored catecholamines will be oxidized. Okay, so oxidation of the stored catecholamines, okay, synthesized by the tumor. This is known as chromaffin reaction. Okay, so just that's enough. Simple. Here the image, chromaffin reaction. Okay, here immunohistochemistry shows positivity for synaptophysin, chromogranin, non-specific esterase and S100 positivity is seen. Zellbalan pattern with sustentacular cells. Okay, gene mutations, red oncogene mutation, one hippolyndro gene mutation, neurofibromatosis type 1 gene mutation as well as HDH, succinate dehydrogenase gene mutation. Okay, associated with when type 2, von Hippel-Lindau syndrome, neurofibromatosis type 1 and Sturge-Weber syndromes. Okay, extra-adrenal pheochromocytomas are called as paragangliomas. That's it. Completed. Okay, pheochromocytoma completed. Okay, pheochromocytoma completed, sir. Okay, next. So what is a neuroblastoma? 1 minute. Neuroblastoma, sir. See, tumor of adrenal medulla. Is pheochromocytoma okay? That is seen in adults, sir, normally. But what is this neuroblastoma? Neuroblastoma means it's the most common tumor of again adrenal medulla only. Same chromaffin cell tumor, but in children. Okay, tumor of adrenal medulla is the most common tumor of adrenal medulla in children. This is not a serious condition, sir. Why? Because in pheochromocytoma, more amount of epinephrine, norepinephrine is getting produced. Here, tumor is there, but not much. Yes, of course, norepinephrine, epinephrine is getting produced, but not much. Okay, so why this neuroblastoma? The neuroblastoma is because of this NMYC. Okay, NMYC. So this NMYC, it's a transcription factor. Okay, amplification of this NMYC oncogene. Okay, so NMYC oncogene, the gene is going to be amplified. Okay, NMYC gene amplification will be seen in neuroblastoma. Pheochromocytoma gene mutations, you know, 4 gene mutations I gave you. Okay, sir, NMYC gene amplification is associated with neuroblastoma. Okay, done, sir. It's seen in children. Most common presentation is going to be just a distension of the abdomen. Abdominal distension is going to be seen. Okay, less likely these patients not have much symptoms. Okay, hypertension is going to be not usually present, sir, not usually present. But important point which I want you to know is, see here I have just kept the rosettes, the flower kind of arrangement. Even here this neuroblastoma, the tumor cells, see how they are looking like. There is rosette appearance. There is rosettes. So these rosettes are called as, on histology, Homer-Wright rosettes. So Homer-Wright rosettes are seen in neuroblastoma, NMYC gene amplification. Okay, so they are Homer-Wright rosettes. Homer-Wright rosettes are seen in neuroblastoma. Homer-Wright rosettes. See how the tumor cells are arranged. It's not a Zell-Ballen pattern. Now it's almost looking like a flower appearance. The petals. Okay, the flower petal appearance. This is called as Homer-Wright rosettes or Homer-Wright pseudo rosettes. Okay. So look here in pathology there are different types of rosettes. Now I am discussing about, say they go in neuroblastoma. In neuroblastoma, what kind of rosettes are seen? Homer-Wright rosettes. Homer-Wright rosettes are seen. Sir, what are these Homer-Wright rosettes? If you ask me, tumor cells, they are arranged like this, like a flowers. Okay, but in the center there is pinkish appearance. You have this pinkish appearance, then it is called as, okay, it's called as Homer-Wright pseudo rosettes. Okay, Homer-Wright rosettes. Okay, Homer-Wright rosettes. See in the center there is pale neutrophil. Okay, pale neutrophil. There is pink color material. But there are something called as, they go flexor. Okay, Wintersteiner rosettes. Okay, flexor, Wintersteiner rosettes. They are seen in retinoblastoma, where there is a clear central clearing will be seen. And there is something called as perivascular pseudo rosettes. Okay, perivascular pseudo rosettes. In the center, blood vessels can be seen. Okay, blood vessels can be seen. So this Homer-Wright rosettes. Okay, Homer-Wright rosettes, sir. The Homer-Wright rosettes are the tumor cells present. In the center, there is pink color appearance. Pale neutrophil is going to be seen, sir. Okay, look here. See, in the center, there is pink color appearance. These are pseudo-Wright. Homer-Wright rosettes. Homer-Wright rosettes, sir. So what are the important points which you need to know regarding the neuroblastoma seen in the children? The most common tumor of adrenal medulla in children, not as serious as pheochromocytomas. Why? Because pheochromocytomas, more complications, more clinical features are going to be seen. Here, not many clinical features are not going to be seen. Hypertension is also not usually seen because of NMYC gene amplification. Okay, histology, like Homer-Wright rosettes. Homer-Wright rosettes are going to be seen with a central pink color appearance. Okay, done, sir. After this, what else you should know? The last one, hyperaldosteronism. This one I have already discussed with you. Hyperaldosteronism. What is the example, sir? Hyperaldosteronism. What is the example? I have given you Conn syndrome. What is the Conn syndrome? There is adrenal adenoma. Okay, adrenal adenoma, sir. There is a tumor in the adrenal gland cortex. That's the cause. Okay, one cause for hyperaldosteronism. More amount of aldosterone is there, but that's not the most common cause. The Conn syndrome or adrenal adenoma is not the most common cause of hyperaldosteronism. Most common cause, if you ask me, most common cause is cortical hyperplasia. Adrenal gland cortex is there, right? This cortex. The adrenal gland cortex have undergone hyperplasia. Hyperplasia of adrenal gland cortex. More cortex means more aldosterone. Okay, so the most common cause of hyperaldosteronism is adrenal gland cortical hyperplasia. The other cause you can say adrenal adenoma leading to Conn syndrome. Okay, adrenal adenoma causing hyperaldosteronism is called as Conn syndrome. You know the features: hypertension because of hypernatremia, hypokalemia can be seen, metabolic alkalosis can be seen. I have discussed with you Conn syndrome, cleared. Now, what happens if the adrenal gland is damaged, total damage, leading to adrenal insufficiency? Okay, so the next topic, one last topic is adrenal insufficiency. What exactly is this adrenal insufficiency? Okay. See, this adrenal insufficiency is also called as AKA. Okay, AKA. See, normally it's insufficiency, sir. Insufficiency means less, right? Less, subtraction. But in the name it will be like addition. Addison's disease. Addison's is not actually addition but subtraction. Means adrenal gland is gone, adrenal gland is getting damaged. So the adrenal hormones like aldosterone, cortisol are going down. So let me write here one by one. Sir, adrenal insufficiency, also called as Addison's disease. There is nothing addition, okay, but subtraction gone. Okay, so also called as Addison's disease. Why? Why the adrenal gland is getting damaged? Why it is getting damaged? The most common cause for the damage of this adrenal gland is tuberculosis. Tuberculosis, yes, it affects the lungs, but not just the lungs, but also adrenal glands. Adrenal TB. Okay, so most common cause is the tuberculosis. What's the most common cause in the world? Autoimmune disease, autoimmune destruction of the adrenal gland. Autoantibodies came and destroyed the adrenal gland. Okay, autoimmune destruction or adrenal TB. Simple. So there is this one condition, okay, which is called as Waterhouse-Friderichsen syndrome. Okay, Waterhouse-Friderichsen syndrome. What is this, sir? Now see, dekho, the adrenal gland is undergoing necrosis. The adrenal gland is undergoing necrosis, sir. This is called as adrenal hemorrhagic necrosis. It is seen in which infection? See, it's seen in meningococcus infection, sir. Okay, meningococci. If you get this infection, meningococcemia, meningococci infection, that meningococci, okay, which is I think the lens-shaped organism. I am not very much good in the microbiology, but anyway, so meningococcal infection is going to cause hemorrhagic necrosis of the adrenal gland. Adrenal gland is gone. When the adrenal gland is gone, adrenal insufficiency. So can you tell me some causes of adrenal insufficiency? TB, autoimmune damage, or adrenal hemorrhagic necrosis, which is called as Waterhouse-Friderichsen syndrome. Because of which organism? Meningococci. So whenever the adrenal gland is gone, what happens? Sir, aldosterone is not there, so hypotension. Aldosterone is not there, so no sodium reabsorption. Sodium levels will go down in the body. Hyponatremia, hypotension. Aldosterone is not there. And cortisol, remember, cortisol is also very much important. Cortisol will also come from adrenal gland only. Cortisol very much important for the maintenance of the tone in the blood vessels. Cortisol is very much important for the maintenance of the BP. Aldosterone is not there, cortisol is not there, so hypotension. Aldosterone is not there. As aldosterone is not there, potassium is not going out. So leading to hyperkalemia. Aldosterone is not there, so protons H+, they are not going out. Protons are accumulating in the body, leading to metabolic acidosis. Okay, metabolic acidosis, sir. There is going to be metabolic acidosis. Okay, and in these patients who are having, like, the adrenal insufficiency, usually patients will also have hyperpigmentation. The exact reason for the hyperpigmentation is not clearly known. There are some theories, but not exactly known, So Addison's disease is usually present with hyperpigmentation. Okay, hyperpigmentation. So with this, hypoaldosteronism is also completed, sir. Okay, hypoaldosteronism is also completed. Okay, so the disorders are completed. Now let me ask you one thing. So imagine there is a person who is having a tumor in his pituitary gland. He is having tumor in his parathyroid gland. He is having tumor in pancreas also. So there are multiple endocrine tumors are there. So what is this condition called as? Multiple endocrine neoplasias. Okay, multiple endocrine neoplasias. How many types of multiple endocrine neoplasias are there? There are two types of multiple endocrine neoplasias. What are they? Sir? Type 1 and type 2. Okay, multiple endocrine neoplasias. One slide. Okay, every time in your exam, 100%, without this, there can be no exam, sir. Okay, 100% the question is going to be there. So multiple endocrine neoplasias are of two types, MEN1 and MEN2. Okay, MEN1 and MEN2. MEN1 is also called as Wermer syndrome, not Werner, Wermer. Okay, Wermer. Okay, multiple endocrine neoplasias, MER. Okay, MER. Wermer. Why? Because Werner is different. That's a progeria. Okay, different syndrome is there. Werner, that's different. So this is Wermer. Okay, multiple endocrine neoplasia is also called as Wermer syndrome. I have explained you. So this type 1, MEN type 1. Okay, multiple endocrine neoplasia type 1. It's a 3P tumors will be there. 3P tumors. What are these 3P tumors? I have explained you. Pituitary tumors, parathyroid tumors, and pancreatic tumors. Pituitary, parathyroid, and pancreatic tumors are there. Okay. Why? Why, sir? Why? Why? Because of a gene mutation. Which gene mutation? MEN1 gene mutation. MEN1 gene which is present on the chromosome number 11. MEN1 gene which is present on the chromosome number 11 when it is mutated, going to cause multiple endocrine neoplasias. Pituitary, parathyroid, pancreatic tumors. Out of these three, pituitary, parathyroid, pancreatic. Pituitary, parathyroid, pancreatic. The most common tumors are parathyroid. Okay, most common tumors are parathyroid tumors. Inheritance pattern is autosomal dominant inheritance pattern. How you will get this disease? Autosomal dominant inheritance pattern. Okay, familiar. So tell me, multiple endocrine neoplasia type 1. How many types of tumors are there? What are the organs involved? Pituitary, parathyroid, pancreatic. Most common are parathyroid tumors. Okay. Especially, actually, what happens is parathyroid hyperplasia will be seen. Not actually tumor, parathyroid hyperplasias are seen. MEN1. Okay. But anyway, what is the gene mutation? MEN1 gene mutation. MEN1 gene is present on which chromosome? Chromosome number 11. What is the inheritance pattern? Autosomal dominant. Next, MEN2. Sir, MEN2 is divided into 2A and 2B, sir. MEN2, it is divided into 2A and 2B. Okay, it is divided into 2A and 2B. Both in 2, see, here also 2 is there. Here also 2 is there, which means some common features are there. Some common features. Do you know what are they? Sir, देखो, MCT. MCT means medullary carcinoma of thyroid. In yesterday's class, go and revise the thyroid disorder, thyroid cancers. Medullary carcinoma of thyroid. Medullary carcinoma of thyroid, cancer of parafollicular C cells, parafollicular cells producing calcitonin, tumor cells in amyloid background. Okay, apple green birefringence under the polarized light. We have discussed in the last class. So, in MEN2A, which is called as the Sippel syndrome, dekho. Okay, MEN2A is also called as the Sippel syndrome, where the patient is going to have MCT, medullary carcinoma of thyroid gland, and pheochromocytoma. Just now we have discussed pheochromocytomas. So pheochromocytoma here also. So both in 2A and 2B, these are common. Medullary carcinoma of thyroid, remember it like MCT and PCT. MCT and PCT are common, sir. Here also MCT, PCT. Here also MCT, PCT. Then what is the difference between MEN2A and 2B? The differences are that in MEN2A, the patients are going to have parathyroid endomas, means parathyroid involvement is going to be seen. In MEN2B, there are mucosal neuromas in the mucosa. Okay, in the mucosa, small tumors will be seen. Okay, small tumors will be seen, which are called as the mucosal neuromas. Okay, and Marfanoid habitus. If you look at this fellow, he is going to have Marfanoid habitus, Marfan syndrome, like slender, thin, tall, with large, like limbs. Okay, so Marfanoid habitus, pectus excavatum can be seen. Okay, and mucosal neuromas. So now tell me, sir, MEN2 is divided into 2A and 2B. 2A is also called as Sippel syndrome. What is common between 2A and 2B? Common things are medullary carcinoma of thyroid as well as pheochromocytoma. This is common between both 2A and 2B. What is the difference, sir? 2A is going to have parathyroid endomas, parathyroid gland tumors can be seen, and 2B, the patient is going to have mucosal neuromas and Marfanoid habitus. Okay, the same here also. Dekho, when MEN1, okay, MEN1, which is also called as Wermer syndrome, okay, Wermer syndrome. See, 3P tumors, parathyroid, pancreatic, pituitary. Parathyroid, pancreatic, pituitary tumors. 3P tumors. Parathyroid, pancreatic, pituitary. Mainly it's a parathyroid hyperplasia. There also I have explained. Parathyroid, not a tumor. Parathyroid hyperplasia is most common. MEN2A, also called as Sippel syndrome. What are the common things? See, pheochromocytoma, medullary carcinoma of thyroid. Here also pheochromocytoma, medullary carcinoma of thyroid, common. But in 2A, parathyroid involvement will be there. Parathyroid hyperplasia, parathyroid adenomas can be seen. In 2B, the Marfanoid habitus, mucosal neuromas can be seen, sir. Mucosal neuromas can be seen. So with this, the important topics which you need to know for your exam. Okay, thyroid disorders, parathyroid disorders, adrenal disorders. Okay, so hope the class is helpful. From tomorrow, we can start with the new pathology. Most probably, we'll be doing with the lung pathology. Okay, we'll be starting with the lung pathology, sir. The respiratory system will be doing with the respiratory system. Okay, so hope the class is helpful. Okay, guys, bye bye for today. See you tomorrow.